Welcome, Nclex RN test takers, to the deep dive. Today, we're embarking on a really crucial journey into the heart of psychiatric mental health nursing.
Mhm.
I know mental health concepts can sometimes feel incredibly vast, maybe a bit overwhelming, but our mission today is simple. We want to make this complex material, digestible, highly relevant, and absolutely test ready for your Nclex examination.
Exactly.
In guiding you through this deep dive, I'll be your clinical coach, focusing on the why behind what we see in our clients. We'll connect the dots between symptoms and the underlying clinical concepts, aiming to give you that holistic understanding.
And I'll be breaking it down into those test smart nursing strategies. So we'll zero in on therapeutic communication, client safety, and those all-important priority actions that Nclex loves to test, ensuring you're not just memorizing, but truly applying the knowledge.
Okay, so to begin our exploration, let's start with the foundational pillars of psychiatric mental health nursing. Our first stop is the therapeutic nurse-client relationship, which is really your compass for connection in this crucial field.
Absolutely fundamental.
This relationship isn't just a nice to have, it's the bedrock upon which all effective mental health care is built. The core principles here are genuineness, respect, and empathic understanding. These aren't just buzzwords.
Not at all.
They're vital for building trust and truly seeing your client, acknowledging their unique experiences. We aim to view every client holistically, which means always considering their unique cultural, spiritual, and personal beliefs.
Right. That holistic view is key.
This comprehensive approach allows us to provide care that truly resonates with them, making them feel heard and valued.
And this foundational relationship, while it fosters that deep connection, it also requires clear structure. It's just as important to establish appropriate limits and boundaries.
Okay.
This ensures a safe, professional, and consistent environment, which is especially vital for clients who may have experienced boundary violations in the past. Trust is built on honest and open communication, and without that, progress is incredibly difficult.
Makes sense.
The ultimate goal of this relationship isn't just to make the client feel better in the moment. It's really to help them develop problem-solving abilities and effective coping mechanisms that they can use long after they've left your care.
Empowering them. Right.
Exactly.
Yeah.
Fostering true independence.
So this therapeutic relationship isn't static. It unfolds. Can you walk us through those distinct phases a nurse will navigate, starting even before they meet the client?
Absolutely. And understanding these four phases is crucial for your Nclex, as it reflects a structured approach to care. It shows you know the process. First, we have the pre-orientation phase. This happens before you even step into the room to meet the client. It's all about preparation.
Okay, before contact.
Right. You'll be reviewing the client's chart, gathering essential information like their diagnosis, history, any previous treatments. But just as importantly, you're engaging in self-reflection.
Looking inward first.
Exactly. This means examining your own thoughts and feelings about working with that particular client. For example, if you're about to meet someone with a diagnosis you're unfamiliar with, or maybe someone who reminds you of a difficult person from your past,
Right.
recognizing those feelings helps you identify any biases or preconceived ideas you might unknowingly hold. This self-awareness ensures you approach the client with an open mind and a neutral stance, ready to build trust without projection.
So you're not bringing your own stuff into the room.
Precisely. It's about anticipating potential issues and preparing yourself mentally and emotionally for the interaction.
That makes perfect sense. You're setting yourself up for success. Then comes the orientation or introductory phase where the actual connection begins. What are the critical elements there?
Okay, so in this phase, you formally introduce yourself, full name, designation, and you begin to establish rapport. This is like the initial handshake of the therapeutic relationship.
The first impression.
Definitely. This is also the time to clearly set boundaries, discussing the limits of confidentiality, what information will be shared, and with whom, always respecting legal and ethical guidelines. That's huge.
Very important.
You'll also mutually agree upon the goals for your interactions. This creates a shared purpose, right?
Yeah, so everyone's on the same page.
Exactly. And finally, you nail down the practical details, like the date, time, place, and duration of your meetings. This initial contract sets clear expectations, fosters a sense of predictability, and builds that crucial foundation of trust. It's about creating a safe container for the work ahead.
Okay, and after that initial setup, we move into the working phase, which sounds like where the real work happens. What does that entail for the nursing client?
You're right. This is truly the core of the relationship where the bulk of your therapeutic work happens. In this phase, you'll be gathering more in-depth data, continuously assessing the client's needs and challenges.
The assessment piece is ongoing then.
Always. And you'll actively identify and practice problem-solving and coping skills with the client. Notice I said with them.
Right, not for them.
Exactly. It's a collaborative process of teaching and rehearsing new strategies. You'll provide essential education tailored to their specific needs, whether it's about medication, their diagnosis, or healthy lifestyle choices. And throughout, you're continuously evaluating their progress toward those mutually set goals. It's an active, dynamic stage.
So lots of back and forth, lots of engagement.
A lot of engagement. The client explores their concerns, confronts their challenges, and you assist them in developing effective, sustainable strategies.
And finally, a phase often overlooked but incredibly important for the client's long-term well-being, the termination or separation phase.
Yes, and while it marks the end of the formal relationship, preparation for this phase actually begins from your very first contact.
Oh, interesting. So you're thinking about the end from the beginning.
In a way, yes. From day one, you're helping the client build skills for independent functioning. As you approach termination, you'll summarize the goals that were achieved throughout the relationship, reinforcing their progress and successes.
Celebrating the wins.
Absolutely. It's also vital to discuss how the client can incorporate the new coping skills and problem-solving abilities into their life outside of the therapeutic setting, and planning for their discharge and ongoing support.
Planning for aftercare.
Crucial. And this is critical. It's absolutely necessary to allow the client sufficient time to share their feelings about this separation. It can often elicit a sense of grief, much like any other significant loss.
A real sense of loss, yeah.
Dismissing these feelings can undermine all the progress made. You have to validate that.
Now, within these relationships, there are two critical, almost invisible forces you need to be aware of because they can profoundly impact care. The first is transference. What is it, and how does it manifest?
Right, transference. It's when the patient unconsciously redirects or transfers feelings and attitudes about a significant person from their past onto the nurse.
Okay, like projecting past feelings onto the present person.
Exactly. Think of it as old feelings finding a new, current target. For example, if a nurse reminds a patient of, say, an overbearing parent, the patient might treat the nurse with unexpected hostility or maybe an exaggerated need for approval.
Even if the nurse hasn't done anything.
Even if the nurse has done nothing to warrant it. It's a powerful, often unconscious reenactment of past relationships.
Wow. And the flip side of that is countertransference, where the nurse's own experiences get interwoven with the patient's.
Precisely. Countertransference occurs when your feelings and responses toward the patient are unconsciously influenced by your own past relationships or personal experiences.
So the nurse is projecting now.
Kind of. For instance, if a patient reminds you of a beloved family member who struggled with addiction, you might find yourself overly protective or maybe too lenient with them, blurring those professional boundaries. Or perhaps a client's anger triggers your own past experiences with aggression, leading you to become overly defensive or maybe even withdrawn. Recognizing countertransference is vital for self-awareness in nursing.
So important for staying objective.
It allows you to maintain objectivity and provide the most therapeutic care possible without your personal history interfering. It's why sometimes, in a team setting, if one nurse is really struggling with a particular client's personality, another team member might step in, recognizing that countertransference could be at play. It's a powerful, almost invisible force in our work, isn't it?
It's definitely something to be mindful of.
All right, let's move on to your Nclex superpower, therapeutic communication. This isn't just for mental health settings. It's essential across all nursing practice, from med-surg to peds. And it is highly, highly tested on the Nclex.
So this is core nursing skill, really.
Absolutely. Mastering this skill will serve you well, not only on the exam, but throughout your entire nursing career. It's how you build rapport, assess needs, and ultimately deliver effective care.
That's a great point. And building on that, recognizing the nonverbal cues, especially how anxiety can just shut down communication, that's where true clinical judgment comes in. At its core, communication includes both verbal, what you say, and nonverbal, your body language, gestures, tone expression.
Both are sending messages.
All the time.
Yeah.
What you say, how you say it, and your body language all send messages, often simultaneously. Successful communication is appropriate, meaning it fits the situation and cultural context. efficient, conveying the message clearly without unnecessary words, flexible, allowing you to adapt to the client's needs in the moment, and it always provides feedback, ensuring the message was received as intended.
Checking for understanding.
Exactly.
Yeah.
It's also critical to remember that anxiety, whether in the nurse or the client, can significantly impede effective communication. It's incredibly hard to hear or be heard when either party is highly anxious or distressed.
Okay, let's dive into some specific therapeutic communication techniques you should use. These are your essential tools for building rapport, eliciting crucial information, and empowering the client. First, broad opening remarks are fantastic for encouraging the client to choose the topic and initiate conversation. Think, what would you like to talk about today? Or, tell me what's on your mind.
Puts the ball in their court.
Right, it signals respect for their autonomy. Then we have open-ended questions. These are your go-to for encouraging conversation and getting the client talking beyond a simple yes or no.
So not, are you hearing voices, but
Exactly. Instead, you'd ask, tell me more about the voices you're hearing. Or how does it feel to think you're being watched? This is absolutely critical for assessing risk, understanding the client's perception, and gaining a deeper understanding of their experience.
okay, next. Sharing observations. This is exactly what it sounds like. Stating what you observe about the client's behavior or mood in a non-judgmental way. A simple, you seem a little sad to me today, or I notice you're pacing quite a bit, can open the door for them to share more about their internal state without feeling, interrogated.
Gently opening the door.
Exactly. Clarification or validation is used when something the client says is vague, confusing, or potentially ambiguous. You might say, do I understand you correctly when you say this? Or could you give me an example of what you mean? To ensure mutual understanding and avoid misinterpretation.
Reflection is a really powerful technique where you direct the client's question or statement back to them for their own consideration, encouraging self-exploration. If they ask, do you think I should try that new medication? You could respond with, what are your thoughts on that? Or what pros and cons do you see?
Empowers them to think it through.
Right. It empowers them to think critically and take ownership of their decisions. Offering self means making yourself available and present for the patient, even if it's just by sitting in silence with them, or maybe by holding a hand if culturally appropriate and welcomed. It shows you're there for them, providing a comforting, non-demanding presence.
Restating involves repeating the core of what the client said to confirm your understanding and show you're actively listening. If they say, I'm so anxious that I can't get to sleep, you might restate, so your anxiety is keeping you up at night.
Shows you're tracking with them.
Right. It validates their statement and gives them a chance to correct you if you misunderstood. And then there's presenting reality, which is incredibly important in mental health, particularly for clients experiencing psychosis. You acknowledge the client a perception is real to them, but gently correct misconceptions about shared reality.
Okay, how does that say exactly?
So if they're hearing voices, you'd say something like, I understand that you're hearing voices, but I do not hear any voices. You validate their experience and feelings without validating the hallucination itself, maintaining your own connection to reality.
Got it. Gentle but firm on reality. Other valuable techniques include silence, which gives the client time to gather their thoughts, process emotions, or decide what to say next. Appropriate eye contact, which conveys attentiveness and respect. And therapeutic touch, always considering individual and cultural appropriateness, as it can provide comfort and connection when words are not enough. The key is to use these tools deliberately and with purpose. Now, as you apply this knowledge, be acutely aware of what not to do. Here's a critical concept Nclex loves to test, a true pitfall if you're not careful. Non-therapeutic communication techniques you must avoid. These can hinder rapport, invalidate feelings, and just shut down communication.
Okay, the do not use list. First up, false reassurance. Saying everything is going to be just fine in the end is, well, it's unhelpful and often damaging.
Right, because you don't know that.
You don't know that, and it invalidates their current feelings of distress, making them feel unheard or dismissed. It can actually increase their anxiety because it just bypasses their concerns.
Next, passing judgment, whether approving or disapproving, is a definite no-go. For example, saying, yes, you did the right thing, or expressing disapproval. As nurses, our role is to be non-judgmental and supportive, allowing clients to explore their feelings and choices without our personal opinions influencing them.
Judgment creates barriers.
Big time.
Giving advice is another big one to avoid. Statements like, you should or you shouldn't prevent the client from problem-solving independently and developing their own coping skills. Our role is to facilitate their self-discovery and empower their choices, not to provide ready-made solutions that may not fit their life or their values.
Closed-ended questions are generally non-therapeutic in a psychiatric setting. These are questions that elicit only a yes or no answer, like, are you feeling sad? They shut down conversation instead of opening it up.
Dead end.
And don't provide the depth of information needed for a thorough assessment or therapeutic exploration. They're fine for quick factual checks, maybe, but not for understanding internal states.
And definitely avoid why questions. Why are you so angry? Immediately puts the client on the defensive. Often they don't even know why they feel a certain way, and asking puts them in a position of justifying rather than exploring their feelings and behaviors in a safe space.
Yeah, it can feel like an accusation.
It really can.
Leading or biased questions are also non-therapeutic. For example, you don't smoke, do you? This suggests a desired answer and can make the client feel pressured to respond in a way that isn't honest, undermining trust. Finally, changing the subject is a clear signal that you're avoiding the client's thoughts, feelings, or concerns, implying they are unimportant. We want to show the client that their feelings matter and that we are present and engaged.
Got it. Avoid the pitfalls. Stick to the therapeutic techniques. All right, let's transition now to how individuals protect themselves psychologically, especially when facing overwhelming emotions. We're talking about coping and defense mechanisms, protecting the self. To start, coping mechanisms are basically any conscious or unconscious effort a person makes to decrease anxiety.
Any effort.
Right. These efforts can be constructive, helping them deal with the stress in healthy ways, or they can be destructive, potentially causing more problems in the long run. Think of them as strategies, some helpful, some less so.
That's right. And defense mechanisms are actually a type of coping mechanism, often operating unconsciously. They're primarily used to protect the individual from overwhelming anxiety, essentially safeguarding their ego when faced with a threat or internal conflict.
Protecting the self.
Exactly. They're automatic, often unconscious processes that serve to reduce distress by distorting reality in some way. For example, denial is a common defense mechanism where someone refuses to accept a painful reality.
Here's where it gets really interesting for your practice, I think. Your role as a nurse isn't to just strip away these defense mechanisms immediately, even if they seem maladaptive from an outsider's perspective.
Right, that's key.
They're there for a reason. They're protecting the client, even if it's in an unhealthy way sometimes.
This is a crucial concept for the Nclex, so listen closely. You should know this. The profound insight here is recognizing that these defenses, while sometimes maladaptive, are the client's current shield against overwhelming distress. Removing it without a replacement leaves them dangerously vulnerable.
Like taking away a crutch.
Exactly, like taking away a crutch from someone with a broken leg without providing a wheelchair. Your primary role is to help the client identify the source of their anxiety, explore various methods to reduce it, assess their current use of defenses, and then facilitate the appropriate and constructive use of those mechanisms, or maybe help them develop new, healthier ones.
So you work with the defenses first.
You work with them, you understand them, and critically, you should never criticize their behavior or their use of these defenses. It's about understanding, supporting, and building healthier alternatives. We don't judge, we support growth.
With that compass of connection in hand, the therapeutic relationship, and an understanding of how clients protect themselves, let's now apply those principles as we navigate the diverse landscape of mental health disorders. We'll start with one of the most universal human experiences, anxiety disorders, from worry to panic.
Very common.
Everyone experiences anxiety. It's a normal, often useful response to stress. It can even be motivating, right? Pushing you to study for your Nclex or prepare for a big presentation.
A little bit can be good.
But pathological anxiety is different. This is when the intensity of the emotional response is way out of proportion to the actual threat. Or it persists long after the threat has passed, or maybe it generalizes to situations that are actually benign. It significantly impairs functioning, moving from a helpful motivator to a debilitating force. We often break anxiety down into distinct levels, and understanding these levels is key for your nursing priorities. Mild anxiety is like the tension you feel before a big exam. It actually increases your perception, sharpens your senses, and can be motivating, enhancing creativity and learning. You might feel a little restless or irritable, but it's manageable.
Functional anxiety.
Right. Then, at the moderate level, your perceptual field narrows a bit. You might experience selective inattention, focusing only on immediate concerns, but learning can still occur, perhaps with some difficulty. Physical symptoms like an increased heart rate, perspiration, maybe a headache might start to appear.
Okay, starting to feel it physically.
Yeah.
As anxiety escalates, we hit severe anxiety. Here, there's a significant narrowing of the perceptual field, and the client might focus only on minute or scattered details. Problem solving is no longer possible.
Brain shuts down for problem solving.
Completely. All behavior is aimed at relieving that intense anxiety.
This podcast is brought to you by Nclex Review Pro, your trusted platform for smarter, high-yield Nclex RN preparation. Our motto, prep like a pro. Let the worries go. Visit nclexreviewpro.com to explore all resources.
Increased heart rate, perspiration, maybe a headache might start to appear.
Okay, starting to feel it physically.
Yeah.
As anxiety escalates, we hit severe anxiety. Here, there's a significant narrowing of the perceptual field, and the client might focus only on minute or scattered details. Problem solving is no longer possible.
Brain shuts down for problem solving.
Completely. All behavior is aimed at relieving that intense anxiety. Physical symptoms caused by overwhelming stimulation of the sympathetic nervous system include a pounding heart, hyperventilation, dizziness, severe sleep disturbances. The individual truly needs clear, direct instruction to focus, as their own cognitive processes are just overwhelmed.
And finally, the most extreme level is panic. This is associated with dread, terror, and an overwhelming sense of impending doom. There's profound disorganization, difficulty perceiving reality, and an inability to concentrate or communicate effectively.
Can't function at all.
Right. The client might show increased motor activity, like frantic pacing or shouting, or they might withdraw completely, becoming almost catatonic. If prolonged, panic can lead to physical exhaustion and even death due to the extreme physiological stress.
So the key insight here for your clinical judgment is understanding that the level of anxiety profoundly dictates your immediate nursing priority. You wouldn't try to teach coping skills to someone in panic. Your first job is ensuring their safety and addressing basic physiological needs.
Safety first, always.
Always. Let's focus on generalized anxiety disorder, or GAD. This is characterized by unrealistic, persistent, and excessive worry about everyday concerns. Present more days than not for at least 6 months. This pervasive and uncontrollable worry causes significant physical and/or psychological symptoms. It's also more commonly diagnosed in females.
The symptoms of GAD include that excessive anxiety and worrying that lasts for more than 6 months, along with persistent fatigue, a feeling of being on edge or restless, irritability, muscle tension, and insomnia or disturbed sleep. It's just pervasive worry.
Exhausting.
Totally. When diagnosing GAD, it's really important to rule out any underlying medical disorders that might mimic anxiety, such as hyperthyroidism, which can cause similar symptoms like nervousness, tremors, and a rapid heart rate.
Gotta rule out the physical first. Treatment for GAD typically involves a combination of approaches. Talk therapy, especially cognitive behavioral therapy, or CBT, is highly effective in helping clients change negative thought patterns and develop healthier coping strategies.
CBT is big for anxiety.
Very big. Medications commonly used include SSRIs and SNRIs, which target neurotransmitters. Benzodiazepines may be used for short-term, acute relief due to their rapid action, but they carry a risk of dependence, so you have to be careful there.
Short-term only, ideally.
Ideally. Atypical anxiolytics like buspirone offer a non-addictive option for managing chronic anxiety. In terms of nursing care for anxiety, a core intervention is to teach patients how to recognize the signs of escalating anxiety early before it becomes overwhelming.
Catch it before it peaks.
Exactly. Then, we teach them practical interventions to help decrease that anxiety, such as deep breathing exercises, progressive muscle relaxation, and engaging in physical exercise. These are empowering strategies that give clients a sense of control. Now, here's a critical concept Nclex loves to test, a true pitfall if you're not careful. Nclex pitfall alert. If a patient is experiencing severe or panic-level anxiety, problem solving is not possible. Their cognitive functions are overwhelmed, and they cannot process complex information or learn new skills in that state.
Can't learn when you're panicking.
Not at all. Therefore, your nursing care should immediately focus on the patient's safety and their basic physical needs. This means you must rapidly decrease environmental stimuli by providing a calm and quiet environment. You might literally need to help them breathe, provide short, simple commands, and ensure they don't harm themselves or others, rather than trying to reason with them or ask them to articulate their feelings. Their brain is just in survival mode.
Immediate safety, decreased stimuli. Got it. Beyond GAD, there are other important specific anxiety disorders to be familiar with. One is social anxiety disorder, where individuals experience intense anxiety related to social situations due to a pervasive fear of humiliation, embarrassment, or rejection. It's not just shyness, it's debilitating fear.
Really impairs their life.
Totally. Another is agoraphobia, which literally translates to fear of the marketplace. Clients with agoraphobia experience profound anxiety related to public transportation, being in crowds, or being outside the home, feeling they might be trapped or unable to escape to a safe place. This can severely limit their mobility and independence.
Can make them housebound.
It really can. And then, of course, we have specific phobias, where anxiety is produced by a particular object or situation. Common examples include arachnophobia, the intense fear of spiders, or claustrophobia, the fear of confined spaces. The fear is typically irrational and disproportionate to the actual threat.
Right. Treatment for these often involves behavioral therapy, such as systematic desensitization,
Gradually facing the fear.
which gradually exposes the individual to the feared object or situation while teaching relaxation techniques, along with anti-anxiety medications as needed to manage acute symptoms. And just to reinforce an essential safety principle, always stay with a client who is experiencing anxiety, especially severe or panic-level anxiety. Your calm, consistent presence promotes safety and security, letting them know they are not alone. And remember, for specific phobias, you must never force contact with the phobic object or situation.
Okay, never force it.
Never. This can be traumatizing, increase their anxiety tenfold, and be completely counterproductive to therapy, eroding any trust you've built. It's about gentle exposure, not confrontation.
All right, let's shift gears now to bipolar disorder, the highs and lows. This is a significant mood disorder characterized by recurrent cycling periods of extreme lows, which manifest as major depression, followed by extreme highs, known as acute mania.
Big swings.
Huge swings. It's a profound shift in energy, mood, and activity levels that can be incredibly disruptive to a person's life and functioning.
Here's a high-yield mnemonic for you. Think of in bipolar like a bicycle.
Okay, bicycle.
Right. A bicycle has two wheels, representing the two distinct moods, the highs and the lows that cycle, much like the wheels of a bicycle turn. It helps you remember the two contrasting poles of the disorder and its cyclical nature.
Nice visual. Now let's break down the types of bipolar disorder, as they have different characteristics and severity, which are important distinctions for your Nclex. Bipolar 1 is considered the most severe form. It's characterized by one or more episodes of acute mania, which typically last over 1 week, or are severe enough to require hospitalization to ensure the client's safety and stabilize their mood. This is the classic presentation of dramatic mood swings, often involving psychosis.
So, full mania, often needing hospitalization. Then you have bipolar 2. This type involves recurrent episodes of major depression alternating with periods of milder hypomania.
Hypomania, so less intense mania.
Less intense, exactly. While hypomania is a less intense form of mania, it still involves a noticeable and sustained elevated, expansive or irritable mood and increased activity or energy. Crucially, it causes a noticeable change in functioning, but is not severe enough to cause marked impairment or require hospitalization, unlike acute mania.
Okay, noticeable change, but not hospitalization level severe.
Right. And very lastly, there's cyclothymia. This is a milder chronic form where individuals experience milder lows, dysthymia, and milder highs, hypermania, that cycle over a period of at least 2 years. The mood swings aren't as severe as in bipolar or 2, but they are chronic and can still significantly impact relationships and work.
So milder but persistent ups and downs. And sometimes clients experience rapid cycling. What's that?
Rapid cycling occurs when the cycling of depression and mania happens very frequently, specifically 4 or more mood episodes within a 12-month period. This can be incredibly disruptive to a client's life and makes treatment more challenging due to the constant fluctuations.
4 or more episodes a year. Wow.
Yeah, it's a lot. In terms of pathophysiology and risk factors, while the exact cause of bipolar disorder is currently unknown, genetics play a really significant role.
Friends and families.
Strongly. If a family member has bipolar disorder, clients are about 10 times more likely to develop it themselves, highlighting a strong inherited component. Research also points to dysregulation of neurotransmitters like norepinephrine, dopamine, and serotonin. Okay, this is a crucial point for the exam. A genuine Nclex red flags, ol Nclex pitfall alert. Selective serotonin reuptake inhibitors, or SSRIs, which are common antidepressants, can actually trigger a manic episode in susceptible individuals.
Wait, Antidepressants can trigger mania.
In people with bipolar disorder, yes, especially those with undiagnosed bipolar disorder. So if you see a client presenting with manic symptoms who has recently been started on an SSRI, that should immediately raise a red flag. It can push them into the highs more quickly or intensely, destabilizing their mood.
Good to know. Okay, when it comes to assessing clients, most exams emphasize the signs and symptoms of acute mania. This is where things can get incredibly dramatic, and you'll often see these clients needing immediate nursing intervention for safety and stabilization. We can use the mnemonic mania to remember the key features.
We'll break it down.
The M stands for more energy and mood swings. Clients in a manic phase are often overtly euphoric, overly cheerful, and incredibly impulsive. They also exhibit grandiosity, believing they are bigger than life or have supernatural powers.
Like they can fly or talk to God.
Right, sometimes even with hallucinations and delusions of grandeur, like thinking they're the president or have a special meeting with the queen. Their judgment is often severely impaired, leading to reckless behaviors like excessive spending or promiscuity.
The first A is for agitation. Clients can be easily angered and may become irritable or even aggressive when their grandiose plans are thwarted or when they're simply overstimulated. This can quickly escalate to verbal or physical aggression, so setting firm, consistent limits is extremely important for everyone's safety.
Next, the N is for nonstop talking, often with pressured speech that is difficult to interrupt. They might also exhibit rapid, continuous shifts in thought called flight of ideas, where one thought quickly leads to another without a logical connection.
Like a pinball machine in their head.
Exactly. And they might also make very colorful, bizarre clothing choices, standing out in a crowd, reflecting their disinhibition and inflated self-esteem.
The I represents insomnia. Clients in a manic phase can't sleep for days due to their excessive energy, or they might genuinely believe they don't need sleep because they're so full of vitality and important ideas.
But that lack of sleep must make things worse.
Absolutely. This severe lack of sleep further exacerbates their symptoms, leading to exhaustion and increased irritability.
And finally, the last A is for attention span that is poor. Clients are easily distracted by environmental stimuli, making it incredibly difficult for them to focus on one thing for very long. They may jump from topic to topic, unable to complete tasks or follow conversations.
Okay, this is a key Nclex moment, a true clinical judgment cue. You should know this. When assessing a client in a manic phase, look for that nonstop physical activity, poor nutritional intake, and constant delusions. These symptoms are critical because they require immediate nursing intervention, prioritizing their physiological needs and safety above all else.
Physiological needs first.
Always. A client who is constantly moving, not eating, and experiencing profound thought disturbances is at high risk for exhaustion, dehydration, electrolyte imbalance, and accidental self-harm. You need to intervene immediately. So let's break down nursing interventions for acute mania, always prioritizing client safety and stabilization. Firstly, we need to reduce stimulation. Provide a quiet, calm environment, ideally a private room near the nurse's station.
Near the station for observation.
Right. It might sound counterintuitive, but it allows for close, discreet observation without increasing stimuli, offering a sense of security and containment for the client, and allowing staff to easily intervene if agitation escalates. This means limiting group contact. No dining rooms or large group activities that might overwhelm them. Opt for one-on-one activities with the nurse instead.
Secondly, we can encourage physical exercise with staff to help them burn off that excess energy in a safe, structured way. This isn't about exhausting them, but providing a constructive outlet.
Like walking or simple tasks.
Yeah. Examples might include alternating aerobic exercise with scheduled periods of rest, or even assisting with sweeping the floor of the unit, which can provide a sense of purpose. These activities help channel their hyperactivity in a safe and productive way, reducing agitation.
Third, it's vital to set structure and limits on aggression and impulsivity. Clients in a manic phase are easily distracted, often very irritable, and prone to boundary violations. A common Nclex tip here. You should know this. Nurses may actually need to choose clothes for the client to help set structure and reduce the overstimulation or bizarre choices that can come with impaired judgment.
Helping them choose clothes. Really?
It sounds small, but it helps provide a sense of control and routine. You must also set firm, consistent limits and be consistent with consequences for aggressive behavior. For example, if a client throws a lamp, they need to understand that the consequence will be staying in their room for a specific, predetermined period. Consistency is key.
Consistency prevents manipulation.
Right, exactly, as these clients will often test limits.
And finally, to address their poor nutritional intake and risk for dehydration from constant activity, we need to provide high-calorie finger foods and fluids.
Food on the go.
Right. Manic clients are often too busy, too distracted, or simply too energetic to sit down for a full meal. So easy-to-grab, nutrient-dense options like sandwiches, fruit, protein bars, and juices are essential to prevent dehydration and malnutrition. Think about items they can eat while moving without needing utensils or a formal dining setting.
Practical solutions.
Let's turn our attention now to depressive disorders. Beyond sadness. Depression is one of the most common psychiatric disorders, profoundly affecting feelings, thoughts, and behaviors, and significantly impacting daily life. When assessing for depression, it's crucial for you as a nurse to rule out the effects of a substance or another medical condition that might mimic depressive symptoms.
Got to check for physical causes first.
Absolutely, especially hypothyroidism, as symptoms can overlap and be misleading.
Exactly. Risk factors for depression are multifaceted. They include a genetic predisposition, it can definitely run in families, and dysregulation of neurotransmitters like serotonin and/or norepinephrine in the brain, which are crucial for mood regulation.
Chemical imbalance.
Often, yes. Inflammatory processes, stressful or traumatic life events, chronic illness, and various psychological factors such as learned helplessness or negative thought patterns can also contribute to its development. It's complex.
The symptoms of major depressive disorder are persistent and pervasive, lasting for at least 2 weeks and causing significant distress or impairment. These include a profoundly depressed mood nearly every day, a diminished interest or pleasure in almost all activities, a state known as anhedonia.
Loss of joy.
Complete loss of joy. You might also see significant weight change or changes in appetite, either loss or gain. Clients may experience insomnia or hypersomnia, either extreme sleeplessness or excessive sleeping. You might observe psychomotor agitation, which is that extreme restlessness like pacing or hand-wringing, or psychomotor retardation, a noticeable slowing of movements and speech.
Everything slows down or speeds up uncomfortably.
Right. There's often constant fatigue or loss of energy, overwhelming feelings of worthlessness or excessive guilt, and a diminished ability to think or concentrate, often leading to indecisiveness. And crucially, there are often recurrent thoughts of death or suicide. These symptoms collectively cause significant impairment in the client's functioning across major areas of their life.
Now, for nursing interventions for depressed clients, our focus is always on safety and promoting their well-being. This is a vital Nclex point. You should know this. For any client at risk for self-harm, you must always ask directly. Have you thought of hurting yourself, or are you having thoughts of ending your life?
Don't beat around the bush.
Absolutely not. This is a priority assessment. Don't dance around the topic, as it opens the door for them to share their critical safety needs. Here's a major Nclex pitfall to avoid in your practice. Old Nclex pitfall alert. Closely monitor both depressed clients and those newly prescribed antidepressants for signs of suicidal ideation. This is especially critical if a client presents with increased energy after starting medication.
The energy paradox again.
Exactly. While improved mood and increased energy might seem positive, this increased energy could mean they now have the motivation and physical capacity to carry out a suicide plan that they previously lacked due to profound lethargy. So, increased energy in a depressed client can actually be a very dangerous sign requiring heightened vigilance.
Increased energy means increased risk, potentially.
Got it.
To help with energy and mood, provide gross motor activities like walking or simple exercises. This can be beneficial even if they initially resist, as physical activity can naturally elevate mood. Offer structured activities or start with one-to-one activities with the nurse.
Starting small.
Starting small, like a short conversation or a simple craft. Gradually introduce them to small and then larger groups as their tolerance and energy improves. When explaining routine procedures or daily plans, provide simple and direct explanations to avoid overwhelming them, using short sentences and concrete language.
Keep it simple. It's vital to monitor nutritional intake and weight, as depression can severely impact appetite. Consider staying with a client during meals to accurately assess how much they're eating and offer encouragement. Also, monitor for general hygiene and self-care deficits, providing gentle prompts as needed, as these can be early indicators of worsening depression or a lack of motivation.
The basics can fall away.
They really can. For sleep, monitor sleep patterns, decrease environmental stimuli at bedtime, and encourage relaxation techniques like warm baths or reading to promote rest. And finally, encourage the expression of sadness or anger, allowing adequate time for verbal responses without rushing them, and always respond therapeutically and non-judgmentally to any anger expressed, as it's often a manifestation of underlying pain.
Okay. Let's move on to schizophrenia. Disordered reality. This isn't just one problem. It's a group of severe mental health challenges characterized by psychotic features like hallucinations and delusions, alongside severely disordered thought processes and profoundly disrupted interpersonal relationships.
A really complex illness.
Very complex. It involves an abnormal, scattered pattern of thinking that lasts for 6 months or more, profoundly affecting areas like relationships, school, and work due to an inability to concentrate and process information logically. It's also unfortunately associated with a high suicide risk, particularly in the early stages or during periods when symptoms might seem to be improving but insight increases.
When we talk about the pathophysiology of schizophrenia, genetics play a huge role. If a parent has schizophrenia, their children are significantly more likely to develop it. While complex, the prevailing theory is that it's primarily caused by a dysregulation, specifically an excess, of dopamine within the brain.
Too much dopamine.
That's the leading theory for the positive symptoms, yes. Other neurotransmitters and brain structures are also implicated, but dopamine is a key player.
Schizophrenia symptoms are typically categorized into 3 main groups for your understanding and for the Nclex. It helps to break it down this way.
Makes it easier to grasp.
First, we have positive symptoms. Think P for psychotic symptoms. These are symptoms that are added to the client's normal experience. They are present in clients who have schizophrenia, but are not present in individuals without the illness. They represent an excess or distortion of normal functions.
Things that are there but shouldn't be.
Exactly. The most common positive symptoms are hallucinations. These are sense perceptions for which no external stimuli exist. For example, auditory hallucinations, hearing voices or sounds that are not there, are the most common type, often perceived as coming from outside the head.
Okay, and this is crucial.
Yes, this is crucial. If a client is experiencing command hallucinations, where voices are telling them to harm themselves or others, client safety is your absolute first priority. You must act immediately to protect them and others.
Safety, safety, safety.
Absolutely. Other types include tactile hallucinations, a sensation of being touched when nothing is there, visual, seeing things that aren't there, gustatory, experiencing taste without stimuli, and olfactory, smelling smells that don't exist.
Then there are delusions, which are false beliefs held to be true, even when there's strong evidence to the contrary. They are unshakable, fixed beliefs that are not amenable to change in light of conflicting evidence.
Fixed beliefs, hard to shake.
Very. You'll encounter types like persecutory or paranoid delusions, where the client believes they are being harassed, threatened, poisoned, attacked, or spied on by powerful forces. This is extremely common and impacts trust. A common example on the Nclex is a client believing the hospital food is trying to poison them.
The poison food delusion, right?
Classic. Then there are delusions of grandeur, which involve an exaggerated sense of self-importance, where they believe they are powerful, famous, or have supernatural powers, like thinking they're a prophet or have a special meeting with the queen. Also important are delusions of reference, where the client believes certain unrelated events, like songs on the radio, TV shows, or news articles, are direct personal messages intended just for them.
Everything's about them.
Right. Or delusions of control, where they believe external forces like the FBI or aliens are controlling their thoughts, feelings, or actions via the internet or some other means.
The third key category of positive symptoms is disorganized speech and thought. This reflects profoundly abnormal thought processes, making communication extremely difficult. You might encounter loose associations or flight of ideas, where there are rapid shifts of thought with no logical connection between one idea and the next.
Just jumping all over the place.
Exactly, like the universe is like a raisin, but the moon is a home and I rode my bike. There's no coherent flow. Neologisms are made-up words that have meaning only to the client, such as, the Volmers are coming to execute me. These words are incomprehensible to others.
Word salad, also called schizophagia, is a severe form where there's a mixture of words and phrases with no meaning, truly a jumble like, here's the chair, moon orange, drank too much. It's completely incoherent.
Just random words.
Totally random. Clang associations involve listing rhyming words together that make no sense in context, like, let's go to the bay, let's hit the hay, what do you say we can go today? They sound like poetry but lack meaning.
Concrete thinking means taking statements literally, unable to grasp abstract concepts, metaphors, or idioms. If you say the grass is greener on the other side, they might think you're talking about actual grass, not a better situation.
Can't understand figures of speech.
Right. Tangentiality is when a client digresses from one topic to another without ever completing the original thought or reaching a conclusion. They simply go off on a tangent. Echolalia is the pathological repeating of another's words, like an echo. If you say, "we will take your vitals," they might repeat, "vitals, vitals, vitals." And perseveration is repeating the same words or phrases when answering different questions, using their own words rather than echoing yours, demonstrating a fixed thought pattern.
Okay, that covers positive symptoms. Our second main category is negative symptoms. Think A for absence or a negative state. These are things that are taken away from the client's normal experience, representing a decrease or loss of normal functions.
Things that are missing.
Exactly. It's almost like a light switch being turned off in terms of emotional expression and motivation.
These include flat affect, an expressionless or blank look with a lack of emotional responsiveness. Anhedonia, the profound inability to experience pleasure in activities that were once enjoyable. Apathy or avolition, a significant lack of interest or motivation in goal-directed activities. And alogia or poverty of speech, meaning reduced volume, reduced fluency, or a general lack of spontaneous comments, making conversation difficult.
This is a key negative symptom for the Nclex, and it's vital for understanding the client's social challenges. You should know this. Anxiety and avoidance of social interaction. Clients with schizophrenia often become profoundly anxious when others are around and prefer to be alone to find relief from sensory overload and paranoia. This negative symptom is particularly impactful because it actively keeps them from forming personal relationships and engaging in social interaction, leading to significant social isolation and further functional decline.
So the negative symptoms really impact their ability to connect.
Hugely.
Our third category is cognitive symptoms. These affect memory, learning, and understanding, significantly impairing daily functioning. Think of the double C's for cognitive and capacity to remember. These symptoms include illogical thinking, impaired judgment, impaired memory, especially working memory, inattention, poor decision-making, and poor problem-solving skills.
Impacts their ability to manage daily life.
Absolutely. These symptoms contribute significantly to the functional impairment seen in schizophrenia, impacting their ability to live independently, work, or maintain relationships.
Now let's talk about nursing interventions for schizophrenia, always prioritizing safety and reality orientation. Your approach needs to be structured and consistent. For hallucinations, first, always ask the client directly about the hallucination to understand its content, especially if it's a command.
What do the voices say?
Exactly. Crucially, avoid reacting to the hallucination as if it were real. Your nonverbal cues are important here. Don't look around as if you hear the voices too. You can decrease stimuli or move the client to another calmer area. For auditory hallucinations, providing earphones and music or turning on the TV can sometimes help the client ignore the internal sounds, especially as antipsychotic medications can take time to become effective.
Distraction techniques.
Right. It's vital to not negate the client's experience by saying things like, "I understand that you're hearing voices, but I do not hear any voices." This validates their reality without validating the hallucination. Focus conversation on reality-based topics and attempt to engage the client's attention through a concrete, simple activity. Avoid touching the client, as it can be perceived as threatening and increase paranoia or anxiety. Monitor for signs of increasing anxiety or agitation, as this may indicate increasing hallucinations. And remember, always ensure safety, especially if there are auditory commands to harm self or others. That's your first and most urgent priority.
Okay. When it comes to delusions, your approach is slightly different. Ask the client to describe the delusion, as this can give you insight into their thought processes and what feelings are driving the belief. Be open and honest in your interactions to help reduce their suspiciousness and build trust. Crucially, focus conversation on reality-based topics, rather than engaging with or validating the delusion directly.
Don't get sucked into the delusion.
Right. Encourage the client to express the feelings that the delusions generate, as the feelings, for example, fear, grandiosity, are real even if the belief is not. If the client obsesses on the delusion, set firm limits on the amount of time spent talking about it to redirect their focus to reality-based issues. You must not argue with the client or try to convince them that the delusions are false. This only builds distrust and resistance.
Arguing never works.
Never. Instead, validate if any part of the delusion is actually real or contains a kernel of truth. For clients with paranoid delusions, especially if they believe their food is poisoned, you may need to alter hospital routines as necessary, such as using canned or packaged food or food brought from home to promote trust and ensure nutritional intake.
Practical ways to build trust. For catatonic schizophrenia, which is characterized by profound immobility, bizarre posturing, muscle rigidity, waxy flexibility where limbs stay in positions they're placed, mutism or severe negativism where they refuse to listen to instructions or move. This is a critical Nclex point. You should know this. The priority for these clients is fluid and nutritional intake due to the high risk of dehydration and malnutrition from their immobility and refusal to eat or drink.
Maslow's hierarchy, right. Physiological needs first.
Always. Physiological needs always take priority over psychological or social needs. These clients may require total body care due to their profound immobility, including assistance with feeding, hygiene, and turning to prevent skin breakdown.
For clients with paranoid schizophrenia, where the key term is persecutory delusions, your interventions should consistently focus on reality. Reinforce it verbally with simple, clear statements. Acknowledge the client's feelings. It must be frightening to think others want to harm you. But crucially, do not focus on the delusions. Discredit them, argue about them, or attempt to explore their meaning.
Focus on the feeling, not the delusion itself.
Exactly. Your goal is to keep them grounded in reality and help them manage their emotional response to their beliefs, not to dismantle the delusion itself.
In terms of general interventions for schizophrenia, providing a safe and structured environment is paramount, as predictability can reduce anxiety. Promote trust through short, frequent contacts with the nurse, calmly sitting with the client for 5-minute intervals initially.
Building trust slowly.
Very slowly. This builds trust without overwhelming them, especially if they are suspicious or have a short attention span. Maintain ego boundaries and avoid touching the client unless it's clearly appropriate, culturally welcomed, and explained, as touch can be perceived as threatening. Use a neutral approach, which is less threatening and avoids overly emotional responses that could be misinterpreted. Do not make promises that cannot be kept, as broken promises erode trust. Assist the client with grooming and personal care, prompting them as needed, as negative symptoms often lead to self-neglect.
Provide simple, concrete activities that do not require high concentration, such as puzzles, simple drawing, or short walks, to engage them without overstimulating. Help the client establish what is real and unreal by consistently orienting them to reality and clarifying misperceptions. Stay with the client if they are frightened. Your calm presence alone can provide immense security.
Your presence is an intervention.
Absolutely. Speak in a simple, direct, and concise manner, avoiding jargon or complex sentences. Reduce excessive stimuli in the environment, which can exacerbate their symptoms. Continuously monitor for suicide risk and assist the client to use alternative means to express feelings, such as music or art therapy, when verbalization is difficult. If their behavior becomes too bizarre or disruptive in a group, gently remove them to a quieter space. Setting realistic goals and gradually introducing choices can also be helpful to foster a sense of autonomy.
Okay, lots of key interventions there.
Let's turn our attention now to personality disorders. Enduring patterns. These are characterized by the consistent expression of inflexible, maladaptive behavioral patterns or traits that significantly impair an individual's functioning and relationships across various contexts.
Enduring, inflexible patterns. That's key.
Right. Unlike psychotic disorders, clients with personality disorders usually remain in touch with reality, but they often lack insight into their own self-identity and interpersonal behavior, including empathy or intimacy. These patterns are deeply ingrained and pervasive. Stress tends to exacerbate these manifestations, making their ingrained patterns more pronounced and difficult to manage.
Yes, and these disorders present with some overarching characteristics that are important to note. Clients often exhibit poor impulse control, leading to acting out behaviors such as physical or verbal attacks, self-injurious acts like cutting, manipulation, substance abuse, promiscuous sexual behaviors, and even suicide attempts.
High-risk behaviors.
Very high risk. Their moods can be characterized by intense emotional dysregulation, with rapid shifts between feelings of abandonment, intense rage, guilt, fear, and a profound sense of emptiness. There's often impaired judgment, a distortion of reality testing in terms of their perceptions of others, and difficulty with object relations, meaning they struggle with stable, intimate relationships and often idealize or devalue others.
Black and white thinking.
Often. They may also have impaired self-perception, experiencing self-hate or self-idealization, and an impaired stimulus barrier, where they struggle to regulate sensory input, leading to increased excitability, agitation, and a poor attention span. For Nclex purposes, it's really helpful to understand the cluster groupings of personality disorders, as this helps organize their distinct characteristics.
Okay, the clusters. First, we have cluster A, which includes the odd or eccentric disorders. This cluster primarily includes paranoid personality disorder, characterized by a pervasive suspiciousness and mistrust of others, interpreting their motives as malevolent. For these clients, it's crucial. Do not whisper or laugh in front of them with other staff.
Oh, definitely not.
They will inevitably think you are talking about or laughing at them, which significantly increases their paranoia and distrust.
Also in cluster A is schizoid personality disorder, where individuals have a profound inability to form warm, close social relationships. They are often aloof, indifferent, and prefer solitary activities, having little desire for intimacy. Then there's schizotypal personality disorder, where clients display abnormal or highly unusual thoughts, perceptions, speech, and behaviors like magical thinking, bizarre speech, or odd beliefs.
Kind of like milder schizophrenia symptoms.
Similar in some ways, but the psychotic episodes in schizotypal personality disorder are typically less intense and less frequent, and they generally maintain better contact with reality.
Now, cluster B contains the dramatic, emotional, or erratic types, and these are often considered the most important for Nclex due to their higher clinical complexity, safety concerns, and frequent presentation in acute care settings.
Yeah, you'll definitely see these on the exam and in practice.
Within cluster B, we have antisocial personality disorder. Despite the name, this isn't about being shy or antisocial in the common sense. It's about a pervasive pattern of disregard for and violation of the rights of others.
Violating rules, lack of remorse.
Exactly. These individuals often have a history of physical violence and animal cruelty starting in childhood. They are aggressive, reckless, manipulative, and notably lack empathy or feelings of remorse, focusing primarily on their own personal gratification and often engaging in deceit.
Then there's borderline personality disorder, characterized by profound instability in interpersonal relationships, an unstable mood, and a fluctuating self-image, leading to impulsive, self-destructive, and unpredictable behavior. They often struggle with an intense fear of abandonment and chronic feelings of emptiness.
Instability is the key word there.
Absolutely. A key feature highly tested is splitting the tendency to see others as all good or all bad, creating conflict by playing one person against another in a black and white perception of the world.
Pitting staff against each other.
Classic splitting behavior. These clients are also at a significantly higher risk for self-harm and suicide attempts, making safety a paramount concern.
Histrionic personality disorder involves overly dramatic and intensely expressive behavior. These individuals crave being the center of attention, may be seductive and provocative in their interactions, and exhibit exaggerated emotions that can seem theatrical or shallow, often shifting rapidly.
Center of attention is key there. And finally, narcissistic personality disorder is marked by a grandiose sense of self-importance, a pervasive pattern of grandiosity, a need for admiration, and a profound lack of empathy. They expect special treatment, often overestimate their own abilities, and will take advantage of others to meet their own needs. Beneath the facade of superiority, they often have fragile self-esteem.
Okay. Our last group is cluster C, which encompasses the anxious or fearful personality disorders. Here, we find avoidant personality disorder, characterized by social withdrawal and extreme sensitivity to potential rejection, driven by pervasive feelings of inadequacy and low self-esteem. They deeply desire social connection, but are paralyzed by fear of criticism.
Fear of rejection holds them back. There's also dependent personality disorder, where individuals exhibit an intense lack of self-confidence and low self-esteem, making them unable to function independently. They passively allow others to make decisions for them in major areas of their life, often focusing on pleasing others and having an excessive need to be taken care of.
And finally, obsessive-compulsive personality disorder. These individuals have difficulty expressing warm emotions, are perfectionistic, stubborn, and have a strong need to control others and their environment. They are typically devoted to work, inflexible, and rigid rule followers.
Important note here, this is different from obsessive-compulsive disorder, OCD.
Right, OCD is the anxiety disorder with obsessions and compulsions.
Exactly. This is a personality style, a pervasive pattern of preoccupation with orderliness and control. Now, for general interventions for clients with personality disorders, our top priority is always to maintain safety, particularly against self-destructive behaviors, which are common, especially with borderline personality disorder. It's crucial that the entire healthcare team is consistent with information, expectations, and their response to any acting out behaviors.
Insistency, consistency, consistency.
It's huge. Inconsistency can be a major problem for these clients, who often test boundaries, and a unified approach prevents splitting.
We should allow the client to make choices and be as independent as possible, fostering autonomy within safe limits, as they often struggle with a sense of control. Encourage the client to discuss their feelings rather than acting them out. Developing a written safety or behavioral contract with the client can also be a very effective tool, clearly outlining expectations and consequences.
Makes things concrete. It's vital to identify splitting behavior and assist the client to deal directly with their anger or other intense emotions rather than triangulating staff. Most importantly, consistently set and maintain firm limits to decrease manipulative behavior and impulsivity. This provides the crucial structure and predictability that these clients often need, even if they initially resist it, and helps them learn more adaptive ways of interacting.
Firm boundaries are therapeutic.
Absolutely.
Let's shift our focus now to safety and crisis management, which are absolute nursing priorities, especially on the Nclex, where you'll always be asked to prioritize safety. We'll start with suicidal behavior, direct assessment and prevention. Suicidal clients often experience overwhelming feelings of worthlessness, guilt, and hopelessness, feeling utterly unable to go on with life. As nurses, we must always consider the possibility of suicide in depressed clients or any client expressing hopelessness or despair.
It has to be on your radar.
It's a non-negotiable part of our assessment and ongoing vigilance.
Indeed. It's vital to know the individuals at risk for suicide. This includes clients with a history of previous suicide attempts. This is the single strongest predictor of future attempts.
Past behavior predicts future behavior.
Often, yes. Also at risk are those with a family history of suicide, and specific demographics like adolescents, older adults, and those who are disabled or terminally ill. Clients with personality disorders, organic brain syndrome or dementia, depressed or psychotic clients, especially those with command hallucinations, and substance abusers are at increased risk due to impaired judgment and impulsivity.
Lots of overlap with other disorders.
Definitely. We also see high risk in those who have been consistently bullied or rejected, have a history of child maltreatment, or past psychiatric hospitalizations.
Visit NclexReviewPro.com to explore all resources.
The more risk factors present, the higher the concern, and the more vigilant your nursing care must be. It's critical to recognize suicidal cues, both subtle and overt. These can include giving away personal, special, and prized possessions, canceling social engagements, making out or changing a will, or taking out or changing insurance policies. You might also notice positive or negative changes in behavior, such as a sudden calmness or apparent improvement in a severely depressed client. Here's a major Nclex warning, a true red flag for your clinical judgment. So, Nclex pitfall alert. A sudden calmness or improvement in a severely depressed client can be an ominous sign.
That energy thing again.
Exactly. It may indicate that they have now gained the energy and resolve to carry out a suicide plan, which they previously lacked due to profound lethargy. So, increased energy in a depressed client can actually be a very dangerous signal. Other cues include poor appetite, sleeping difficulties, feelings of hopelessness, difficulty concentrating, loss of interest in activities, direct client statements indicating an intent to attempt suicide, and inquiries about poisons, guns, or other lethal items. A sudden deterioration in school or work performance is also a significant concern.
Okay. For suicidal client assessment, your inquiry needs to be direct and thorough. First, assess their plan. Do they have a specific plan? Do they have the means to carry it out, such as access to medications or weapons? Have they decided when or where to carry out the plan?
How specific is the plan?
Right. The more detailed and lethal the plan, and the easier the access to means, the higher the immediate risk. Next, consider their client history of attempts. What attempts occurred in the past and what harm occurred? Was the client accidentally rescued or discovered? Have the methods used in past attempts increased in lethality over time? This gives you a baseline for their risk.
Finally, assess psychosocial factors. Is the client alone or socially alienated from others? Is intense hostility or profound depression present? Are they experiencing hallucinations, especially audio or command hallucinations, telling them to harm themselves or others?
Command hallucinations are a huge red flag.
Huge. Is substance abuse present, as this significantly increases impulsivity and risk, often lowering inhibitions? Have they experienced recent significant losses or a new, serious physical illness? Are there significant environmental stressors or lifestyle changes, such as job loss or relationship breakup? These factors provide critical context for the immediate risk and future interventions. When it comes to nursing interventions for suicidal behavior, this is an absolute non-negotiable priority. You must immediately assess for suicidal intent or ideation, and if present, initiate suicide precautions without delay. Document the client's statements, behaviors, and mood every 15 minutes.
Every 15 minutes. That's frequent.
It has to be. This provides a critical legal and clinical record of your vigilance and interventions. This level of detail is crucial. This is a critical action for your Nclex. You should know this. You must remove all harmful objects from the environment. This includes sharp items, belts, shoelaces, medications, accessible cords, anything that could be used for self-harm. This is an immediate environmental modification.
Securing the environment. And another crucial Nclex directive. You should know this. For clients at risk, do not leave the client alone for extended periods. Instead, provide one-to-one supervision at all times. This constant presence is non-negotiable for high-risk clients, ensuring their continuous safety. Maintain a non-judgmental, caring attitude which encourages the client to talk about their feelings and identify positive aspects about themselves, fostering hope and connection.
Build that connection. Ensure visitors do not inadvertently leave harmful objects in the client's room, as this can be an unexpected source of risk. Educate family and friends. Do not allow the client to leave the unit unless accompanied by a staff member, and continue to assess the client's suicide potential throughout their stay, as risk can fluctuate.
It's not a one-time assessment.
Definitely not. Safety is an ongoing process.
Next, let's discuss aggressive behavior and restraints. De-escalation and safety. It's important to differentiate terms here, as they describe a continuum. Anger is a feeling of annoyance or strong displeasure, which can sometimes be displaced onto an object or person. Aggression, however, is a behavior that can be harmful and destructive when not controlled, often aimed at intimidation or dominance.
And violence.
Violence is the most extreme, involving physical force that is threatening or causes injury to the safety of self and others, often with destructive intent.
It's fascinating because anger is often used by individuals to avoid feelings of anxiety or to express pain when they lack other coping skills. It can also provide a feeling of power in situations where a person feels completely out of control.
So it serves a purpose, even if maladaptive.
It's a defense mechanism, but one that can escalate to violence if not managed effectively. Our role is to help them find healthier outlets.
When assessing for impending aggression, look for a history of violence or self-harm, poor impulse control, and a low tolerance for frustration. Observational cues include defiant and argumentative behavior, raising one's voice, making verbal threats, pacing, agitation, muscle rigidity, a flushed face, and glaring at others.
The warning signs.
Exactly. These are all escalating signs that a client might be losing control and preparing to act out, requiring immediate de-escalation strategies.
For interventions for aggressive behavior, our primary goal is de-escalation, preventing physical harm. Ensure a safe and low-stimuli environment. Remove any potential weapons or objects that could be used for harm. Approach the client calmly and communicate with a calm, clear tone of voice. Be assertive, not aggressive, and always avoid engaging in verbal struggles or power plays.
Calm yourself.
Absolutely critical. Maintain a large personal space, at least 2 arms length, and use a non-aggressive posture, keeping your arms at your side, not folded, and avoiding direct eye contact that might be seen as challenging. Listen actively and acknowledge the client's anger, stating, "I can see you're very angry right now. What's upsetting you?" Try to determine what the client considers to be their personal needs or triggers in that moment. Provide clear options that deal with the client's behavior, set firm limits, and make them aware of the consequences if their behavior escalates. If the client cannot control angry behavior that may lead to violence, then discussing the use of restraints or seclusion becomes a necessary last resort intervention.
Okay, let's talk about restraints, security devices, and seclusion. These are serious interventions used only as a last resort. Physical restraints are any physical or environmental means of controlling an individual's behavior that inhibits free movement, such as padded wrists or ankle restraints, or even a bed alarm used to restrict movement.
Things that limit movement. Seclusion is a type of restraint where a client is confined alone in a specially designed, safe room for protection and close supervision, from which they cannot freely exit. Chemical restraints are medications given for the specific purpose of inhibiting a particular behavior or movement, impacting the client's ability to relate to the environment.
Okay, the different types.
Now for the legal and ethical considerations, and this is highly tested on the Nclex, a major red flag for your clinical judgment. 2. Nclex, pitfall alert. Restraints and seclusion should never be used as punishment, for staff convenience, or as a routine intervention. Their use is strictly regulated.
Only for imminent danger.
Exactly. They're used only when a client's behavior is physically harmful to themselves or others, and when all alternative or less restrictive measures have been tried and are clearly insufficient in protecting the client or others from harm. This is a crucial distinction.
A primary healthcare provider's PHCP prescription is generally required prior to the use of restraints or seclusion. However, in emergency situations where immediate intervention is needed to prevent harm, a qualified nurse may initiate these interventions.
The nurse can initiate in an emergency.
Yes, but a written or verbal prescription must be obtained as soon as possible thereafter, typically within a very short time frame, usually 1 hour. The order must specify the type of restraint, the duration, and the circumstances under which it can be removed.
And here's another critical directive, a must-know for your Nclex. You should know this. Within 1 hour of initiation, a psychiatrist or other qualified licensed independent practitioner must perform a face-to-face assessment and evaluation of the client. While in restraints or seclusion, the client needs constant one-to-one supervision by a staff member.
Constant eyes on
Constant. Their physical, safety, and comfort needs, like food, fluids, bathroom, and range of motion exercises, must be assessed every 15 to 30 minutes. And all these observations, along with interventions, must be meticulously documented. This meticulous monitoring and documentation are critical for client safety, legal compliance, and demonstrating that less restrictive measures are not effective.
documentation is key.
Always.
Our next major area is substance use disorders, assessment and withdrawal. These disorders, often referred to as addiction, are characterized by complex behavioral and physiological changes. They typically lead to tolerance, where increasing amounts of the substance are needed to achieve the desired effect, and withdrawal symptoms, which are unpleasant or painful physical and psychological symptoms that occur upon cessation or reduction of the substance.
Tolerance and withdrawal, the hallmarks. Let's focus specifically on alcohol use disorders, as alcohol is a central nervous system, CNS depressant, that affects all body tissues and has widespread, often severe, implications. It's important to differentiate between physical dependence, which is a biological need for alcohol to avoid physical withdrawal symptoms, and psychological dependence, which refers to a powerful craving for the subjective effect of alcohol, the feeling it provides, often to cope with emotional distress.
Physical versus psychological need. Risk factors for alcohol use disorder include a strong biological predisposition, meaning genetic and familial links play a significant role. Individuals with depressed or highly anxious traits, low self-esteem, poor self-control, a history of rebelliousness, poor school performance, and poor parental relationships are also at higher risk due to a combination of genetic vulnerability and environmental factors.
When assessing for alcohol use, look for both acute intoxication signs and chronic use indicators. Acute signs include slurred speech, uncoordinated movements, an unsteady gait, restlessness, and confusion. More subtle signs of chronic use or developing problems include sneaking drinks, drinking in the morning to avoid withdrawal, experiencing blackouts.
Forgetting what happened while drinking.
Exactly. Binge drinking, arguments about drinking with loved ones, and missing work or other responsibilities due to alcohol. A key indicator of dependence is increased tolerance to alcohol, where they need more and more to feel the effects. Crucially, your assessment needs to include the type of alcohol consumed, how much, for how long, and when it was last consumed. This detailed history is absolutely vital for predicting the severity and timing of potential withdrawal symptoms.
Gotta get that history. Psychological symptoms often present with alcohol use disorders include depression, irritability, belligerence, hostility, suspiciousness, rationalization of their drinking behavior, social isolation, decreased inhibitions, decreased self-esteem, and significantly denial that a problem exists.
Denial is a big one.
Huge. This denial is a hallmark and often a major barrier to treatment and recovery, as the client genuinely believes they don't have an issue.
Chronic alcohol use can lead to a host of serious complications affecting nearly every body system. These include various vitamin deficiencies, notably vitamin B deficiency, which can cause peripheral neuropathies, and thiamine deficiency, which can lead to severe memory problems like Korsakoff syndrome and Wernicke's encephalopathy.
Serious brain effects.
Very serious neurological complications, characterized by confusion, ataxia, and abnormal eye movements. Other physical complications include hepatitis and cirrhosis of the liver, esophagitis, gastritis, pancreatitis, various anemias, immune system dysfunctions, generalized brain damage, and cardiac disorders like cardiomyopathy. It truly affects multiple body systems.
It's a whole body assault.
It really is.
Yeah.
Now let's talk about alcohol withdrawal, which is a medical emergency that can be fatal if not managed appropriately. Abrupt cessation or significant reduction of chronic alcohol use leads to central nervous system overactivity because the brain, which is adapted to the depressant effect of alcohol, is now suddenly without it, leading to a rebound excitability.
The brain goes into overdrive.
Exactly. Early signs of withdrawal can develop within a few hours after the last drink and typically peak after 24 to 48 hours. If left untreated, withdrawal can progress to severe, life-threatening symptoms, including seizures and delirium tremens.
For assessing alcohol withdrawal symptoms, we often use tools like the CIWA, Clinical Institute Withdrawal Assessment of Alcohol Scale, to quantify symptom severity. Look for signs of CNS overactivity, hypertension, tachycardia, nausea and vomiting, tremors, especially hand tremors, profuse sweating, diaphoresis, anxiety and agitation.
Shakes, sweats, high vitals.
Right. Clients may also experience tactile disturbances like itching, pins and needles, a burning sensation, or even a feeling of bugs crawling on their skin. Auditory disturbances such as sensitivity to sounds or full-blown hallucinations, and visual disturbances like photosensitivity or vivid visual hallucinations can also occur. Other symptoms include headache and profound disorientation.
The most severe manifestation is delirium tremens, or DTs, which usually peaks 48 to 72 hours after cessation or reduction of intake, though it can occur later and typically last 2 to 3 days. This is a profound medical emergency, as death can occur from complications such as myocardial infarction, fat emboli, peripheral vascular collapse, severe electrolyte imbalance, aspiration pneumonia, or even suicide.
DTs are life-threatening.
Absolutely. Manifestations of DTs include intense agitation, anorexia, severe anxiety, frank delirium, profuse diaphoresis, profound disorientation with fluctuating levels of consciousness, fever, often between 100 degrees air and 103 degrees air, severe hallucinations and delusions, insomnia, and significant tachycardia and hypertension. This constellation of symptoms requires immediate and intensive medical management in a controlled environment.
Okay. In terms of nursing interventions for alcohol withdrawal, the first step is to administer prescribed medications, often benzodiazepines like lorazepam, diazepam, or chlordiazepoxide, to manage the symptoms, reduce CNS overactivity, and prevent seizures.
Benzos are key for withdrawal management.
Key, provide care in a non-judgmental, calm, and supportive manner. Check the client frequently and monitor vital signs and neurological signs rigorously, typically every 15 minutes, along with providing one-to-one supervision due to the high risk of seizures and delirium.
Monitor electrolytes too, right? Monitor serum electrolytes, including glucose and magnesium, as balances are common and dangerous. Provide a quiet, non-stimulating environment to reduce sensory overload, and orient the client frequently to reality with simple, concise statements. Explain all treatments and procedures in a quiet and simple manner. It's crucial to initiate seizure precautions.
Padding side rails, suction ready.
Exactly. Padded side rails, suction at the bedside, and protecting the client during a seizure. Offer small, frequent, high-carbohydrate foods, administering antiemetics as needed before meals due to nausea. Monitor intake and output. Assist with activities of daily living and ambulation if they are stable enough. And always allow the client to express their fears in a supportive environment, remembering that their anxiety is profoundly real.
Beyond alcohol, let's briefly touch on other drug dependencies, focusing on their intoxication and withdrawal patterns, as these are frequently tested and require distinct nursing interventions. For CNS depressants, such as benzodiazepines like Xanax or Valium and barbiturates, intoxication will manifest as drowsiness, hypotension, impaired memory, attention, and judgment, an unsteady gait, and slurred speech, much like alcohol intoxication.
Similar presentation to alcohol.
Right. However, withdrawal is what's critically important here. It can lead to nausea, vomiting, tachycardia, diaphoresis, anxiety, irritability, tremors, insomnia, and most dangerously, seizures. Abrupt withdrawal from CNS depressants can be fatal due to severe CNS overactivity.
Cannot stop benzos abruptly. That's critical.
Absolutely critical. For benzodiazepine overdose, flumazenil intravenously may be used to reverse the effects, but it must be used cautiously in long-term users as it can precipitate seizures.
With CNS stimulants like amphetamines, cocaine, and methamphetamine, intoxication presents with dilated pupils, euphoria, hypertension, tachycardia, paranoia, agitation, and dangerous cardiac dysrhythmias. Clients may be hypervigilant and experience grandiosity.
Everything's sped up.
Right. Withdrawal symptoms, conversely, include profound fatigue, vivid nightmares, insomnia or hypersomnia, intense anxiety, agitation, and notably, severe depression and suicidal ideations, often referred to as a crash.
The crash can be dangerous.
Extremely dangerous.
Yeah.
Withdrawal management is primarily supportive due to the significant risk for self-harm and intense cravings.
For opioids, such as heroin, morphine, and fentanyl, intoxication is characterized by constricted pupils, pinpoint pupils, bradypnea, slow breathing, a major safety concern, drowsiness, hypotension, and psychomotor retardation. This is a CNS depression state.
Slowed down pinpoint pupils. Key signs.
Exactly. Withdrawal, however, presents with a constellation of distinct symptoms: tachycardia, diaphoresis, restlessness, dilated pupils, severe body aches, rhinorrhea, runny nose, and lacrimation, tearing, diarrhea, vomiting, tremors, yawning, intense anxiety, irritability, and piloerection, often described as goosebumps. This distinctive set of signs is a prime clinical judgment. Recognize cues moment for the Nclex.
Recognizing opioid withdrawal.
Right, as these signs point directly to opioid withdrawal. An overdose of opioids is extremely dangerous, leading to severe respiratory depression, shock, coma, seizures, and death. Naloxone, Narcan, is the life-saving antidote.
Keep Narcan handy. Finally, hallucinogens like LSD and PCP cause intoxication with agitation, bizarre or violent behavior, paranoia, vivid hallucinations, and elevated vital signs. They distort perception of reality. Withdrawal symptoms, while not typically life-threatening, can include irritability, anxiety, mood changes, headaches, and insomnia. This is a vitally unique feature for your Nclex. You should know this. A unique and important feature of hallucinogen use is the potential for flashbacks.
Flashbacks, like re-experiencing the trip.
Exactly. Unexpected re-experiences of the drug's effects that can occur for extended periods of time after the original use, sometimes years later. Client safety during these flashbacks is always a priority, as they can be profoundly disorienting, frightening, and lead to impulsive or self-harming behaviors. In terms of general interventions for clients with substance use disorder, a fundamental step is to direct the client's focus to the substance use disorder itself and its impact on their life, as denial is often strong. Help them identify situations that precipitate angry feelings or cravings, teaching them trigger identification and avoidance.
Identify triggers. Set limits.
Right. Set firm limits on manipulative behavior and verbal and physical abuse, holding the client firmly accountable to reasonable limits and consistently reinforcing rules with reasonable consequences for breaking them. This provides structure and predictability. Most importantly, encourage participation in group therapy and support groups, such as Alcoholics Anonymous, AA, or Narcotics Anonymous, NA, as these peer-led programs are incredibly effective in long-term recovery, providing ongoing support and accountability.
Peer support is powerful. Before we wrap up this section on substance use, let's talk about a sensitive but important topic for all nurses: substance use in healthcare professionals. It's a reality in our demanding field, and it presents unique challenges.
Indeed. There are suspicious signs that nurses should be aware of in their colleagues. These include frequently reporting that drugs have been wasted without being witnessed by another nurse, or consistently administering maximum dosages of controlled substances to clients when other nurses typically don't.
Discrepancies in narcotic counts or usage.
Exactly. A variance in usual client pain relief. Yay. One nurse's patients are always complaining of pain after medication, while others are fine. Or always volunteering to carry narcotic keys, or choosing shifts and work areas with less supervision or high-controlled substance use, are all potential red flags that suggest diversion or misuse.
As nurses, we have a professional and ethical obligation to report impaired coworkers to protect client safety. It's a difficult but necessary action, prioritizing patient well-being above all else.
It's about patient safety.
Absolutely. The good news is that most impaired nurses can actually return to work through State Board of Nursing Assistance and Monitoring programs, which typically require strict adherence to clearly stated rules and regular drug screens, offering a path to recovery and re-entry into the profession once they demonstrate consistent sobriety and competency. It's about support and accountability.
Okay, let's transition now to psychotherapeutic medications. Nclex Pharmacology Essentials. Understanding psychopharmacology is vital for your Nclex exam. We'll focus on the mechanisms of action, common and serious side effects, and critical nursing implications for each class. This knowledge isn't just about memorizing drug names, it's about understanding how these medications impact your client, what potential dangers to watch for, and what your priorities are as a nurse.
We'll start with selective serotonin reuptake inhibitors, or SSRIs, which are often the first-line antidepressants. These medications work by inhibiting the reuptake of serotonin in the synaptic cleft, thereby increasing the amount of serotonin available in the brain, which in turn elicits an antidepressant response.
More serotonin available.
Right. They are highly effective for major depression, especially when anxiety features are present, as well as for depression with psychomotor agitation. Compared to older antidepressants like tricyclics, SSRIs generally have a relatively lower side effect profile, particularly avoiding severe anticholinergic effects like dry mouth or blurred vision, which often leads to better client adherence.
Fewer bothersome side effects usually. While generally well tolerated, common side effects can include dry mouth, blood pressure changes, meaning they can potentially lower or elevate blood pressure, insomnia or somnolence, feeling sleepy or drowsy, nervousness, and either weight loss or gain. Clients may also experience decreased libido or sexual dysfunction, apathy, and fine tremors. These side effects, while not life-threatening, can impact adherence, so patient education is key.
Gotta manage the side effects.
Now, this is a major Nclex red flag, a serious life-threatening complication that could occur with SSRIs. Nclex pitfall alert. You absolutely must be aware of serotonin syndrome, a potential toxic effect due to excessive serotonin activity in the CNS.
Too much serotonin.
Way too much. Its characteristics include a cluster of symptoms: hyperactivity or restlessness, tachycardia, fever, elevated blood pressure, altered mental status, ranging from confusion to delirium, rapid mood swings, seizures, severe muscle rigidity, and abdominal pain with diarrhea.
A whole constellation of symptoms.
It is. And the risk for serotonin syndrome is greatly increased when SSRIs are given with MAOIs, monoamine oxidase inhibitors, a combination that must be avoided at all costs, requiring a washout period between these drug classes. Also, be aware that some over-the-counter cold medicines containing pseudoephedrine or dextromethorphan can increase the likelihood of serotonin syndrome, so always ask about OTC meds. This is a true medical emergency requiring immediate intervention.
Medical emergency. Got it. When it comes to nursing interventions for SSRIs, you'll want to monitor vital signs carefully as they can cause blood pressure changes and heart rate fluctuations. Inform the healthcare provider if the client experiences sexual dysfunction or a lack of sex drive, as this is a common reason for non-adherence and may require a medication adjustment or alternative.
Don't ignore sexual side effects.
Right. Initiate safety precautions and contact the PHCP if dizziness or significant orthostatic hypotension occurs, as this can increase the risk of falls.
Instruct the client to avoid alcohol while on SSRIs, as alcohol can exacerbate CNS depression and worsen side effects. Administer the medication with a snack or meal to help reduce dizziness, nausea, and lightheadedness. This is a critical safety intervention, a must-know for your Nclex. You should know this. For a suicidal client, you must monitor them closely, especially during periods of improved mood and increased energy levels after starting the medication.
There it is again, the increased energy risk.
It bears repeating. As we discussed earlier, this energy can unfortunately increase their risk for acting on a suicide plan, so vigilance is paramount in the initial weeks of treatment.
Also, educate clients that taking NSAIDs like ibuprofen with SSRIs increases the risk of an upper GI bleed, so alternative pain relief may be needed. For clients on long-term therapy, monitor liver and renal function test results, as altered values may require dosage adjustments to prevent drug accumulation and toxicity. Instruct clients to change positions slowly if they experience a hypotensive effect upon standing to prevent dizziness and falls.
And here's another major Nclex pitfall. Nclex pitfall alert. Educate the client to not discontinue medication abruptly. Abrupt cessation can lead to serotonin withdrawal syndrome, characterized by unpleasant symptoms like GI distress, nausea, vomiting, diarrhea, movement disorders, tremors, dizziness, insomnia, and sensory disturbances often described as brain zaps.
Brain zaps. That sounds unpleasant.
It is. It's crucial for them to taper off the medication under medical supervision to avoid these uncomfortable and potentially distressing withdrawal symptoms. Never stop cold turkey. Okay, next let's discuss antipsychotics, which play a crucial role in controlling symptoms associated with various mental health problems, particularly in schizophrenia and bipolar disorder. They are broadly divided into typical first-generation and atypical second-generation agents.
First up, haloperidol, Haldol, which is a typical or first-generation antipsychotic. It's indicated for schizophrenia to manage positive symptoms like hallucinations and delusions, and also for Tourette's syndrome to help control severe motor and vocal tics. It may even be given with short-acting benzodiazepines like lorazepam for acute aggressive behavior to quickly calm and manage acute agitation in emergency situations.
A common side effect of haloperidol and other typical antipsychotics is dystonic behavior, which includes acute, painful spasms and muscle contractions of the neck, torticollis, face, grimacing, and tongue protrusion. While these are uncomfortable and frightening for the client, they're generally not life-threatening and do not need immediate reporting to the HCP as an emergency. They are typically managed with anticholinergic medications like benztropine.
Manageable side effect, usually.
Usually. However, you must be extremely vigilant for this next condition, as it's a huge, life-threatening emergency often seen with typical antipsychotics like haloperidol. Or Nclex pitfall alert. You must be aware of neuroleptic malignant syndrome, NMS.
NMS, this one sounds serious.
Extremely serious. This is a rare but extremely dangerous complication. The key signs to look for are a cluster of severe symptoms: high fever, profuse diaphoresis, sweating, a rapid change in mental status, confusion, stupor, coma, severe muscle rigidity, and tremors. This is a medical emergency requiring immediate action. This is a critical action for your Nclex. You should know this. If you suspect NMS, your priority action is to immediately hold the haloperidol or any other antipsychotic, assess the patient's vital signs and level of consciousness, and immediately notify the HCP.
Hold the med, assess, notify. Immediately.
Immediately. Do not wait 30 minutes. Do not just document. This is a true medical emergency where every minute counts for the client's survival.
Moving on to clozapine, clozaril, and risperidone, which are atypical or second-generation antipsychotics. These are often preferred due to a lower risk of certain motor side effects. They are indicated for schizophrenia and schizoaffective disorders, especially in clients who have not responded adequately to other antipsychotics. Clozapine, in particular, is often used for treatment-resistant schizophrenia.
Common side effects, which you should teach clients how to manage, include significant weight gain. So teach healthy eating and weight management strategies, as this can lead to metabolic syndrome. Hypersalivation or excessive drooling and sedation are also common, though the sedation usually improves as the client develops tolerance to the medication over time.
Weight gain, drooling, sedation, okay.
Now, this is a life-threatening major Nclex pitfall, especially for clozapine, and Nclex pitfall alert. The major side effect for clozapine that you absolutely must know is agranulocytosis. This means critically low white blood cells, WBCs, specifically neutrophils, leading to severely compromised immunity.
Wipes out the white blood cells.
Exactly. The mnemonic clozapine zaps those WBCs, helps to remember this. The key signs of agranulocytosis are a sore throat, fever, and flu-like symptoms, which indicate an increased risk of serious infection due to compromised immunity. This is a critical action for your Nclex. You should know this. Your priority action, if you observe these signs, is to immediately report them to the HCP. Monitoring complete blood count, CBC, and absolute neutrophil count, ANC, is critical and required weekly for clients on clozapine due to the severe risk.
Weekly blood draws for clozapine. Got it. And another crucial Nclex pitfall, a big contraindication. You should never give clozapine or risperidone to patients with dementia, as studies have shown it can significantly increase mortality, particularly from cardiovascular events or infection in this vulnerable population.
Increased risk of death in dementia patients.
Right. A helpful phrase to remember this is, risperidone, we remove from dementia.
Finally, let's talk about ziprasidone, Geodon, another atypical antipsychotic. It's indicated for bipolar mania or acute psychosis with agitation. While seizures are a possible adverse effect, cardiac issues are actually more common and very serious, making close monitoring essential. This includes significant hypotension and monitoring for widened QT intervals on an ECG.
QT prolongation, that's a cardiac risk.
A major cardiac risk, which can lead to life-threatening cardiac dysrhythmias, such as torsades de pointe, and can even result in cardiac arrest and death.
Here's a mnemonic to help you remember the cardiac risks. Ziprasidone or ziprasidone, it's done prolonged your QT waves and done dropped your blood pressure.
Catchy. So the crucial nursing intervention here is to monitor the ECG and blood pressure closely and regularly. This immediate and continuous assessment is paramount to ensure client safety while they are on ziprasidone, particularly when initiating the medication or adjusting doses.
Monitor ECG and BP. Okay, wow, we've covered a tremendous amount of ground today, and we really hope this deep dive has empowered you with the knowledge you need to succeed on your Nclex.
Yeah, that was a lot, but hopefully really helpful.
We've gone from the foundational principles of the therapeutic nurse-client relationship and essential communication skills to critical insights into anxiety, bipolar disorder, depression, and schizophrenia, and finally to the crucial knowledge about psychotherapeutic medications.
Remember, the core pillars for success on the Nclex and in your nursing career are prioritizing safety, mastering therapeutic communication, and exercising sound clinical judgment. These aren't just topics for an exam.
Not just for the test.
They are skills you will use every single day to provide compassionate and effective care to individuals at their most vulnerable.
So keep practicing these concepts and applying them mentally to different scenarios. The more you think critically and connect the dots between symptoms, interventions, and priorities, the more ingrained this knowledge becomes, building your confidence.
So, as you step into practice, consider this. How will you leverage your deep understanding of therapeutic communication, the nuances of different mental health presentations, and the critical importance of setting consistent boundaries to build profound trust and truly make a difference in the lives of even the most challenging clients you encounter?
You are not just learning facts, you are developing the critical thinking skills to truly care for individuals at their most vulnerable. Keep diving deep, because every nugget of knowledge makes you a more competent and compassionate nurse.
Thank you for joining us on the Deep Dive.
And good luck with your Nclex review. You've got this.